Hey everyone, and welcome. So, you're a first-year psychiatry resident, which means you're building up that psychopharmacology toolkit, right? Well, today we're diving deep and creating a playbook for one very specific tool, paroxetine. You're on rounds, you've got a patient in front of you, and that thought pops into your head. Could paroxetine be the right move here? It's a really common question, because this drug, it's got a very particular personality. So let's get right into it. Think of this as your quick start guide, designed to get you prescribing paroxetine with confidence and, just as importantly, presenting your reasoning to your attending like a pro. Okay, so here's our game plan. First, we'll figure out who the ideal candidate is. Then, we'll map out the dosing and titration. We'll cover the hazards and the big red flags you can't miss. After that, we'll huddle up for some patient counseling tips, and we'll wrap up with the key talking points for your attending presentation. First things first, let's talk about the candidate. Who are we looking for? And what exactly is paroxetine? So, at its core, it's an SSRI. Simple enough, right? You're familiar with those. But here's the kicker, the thing that makes it stand out from the crowd. It has mild anticholinergic actions. And trust me, that's not just some trivia for a pharmacology exam. It has real, tangible effects on your patients. So how does this actually play out in the clinic? Well, the SSRI part is pretty straightforward. That's how it tackles depression and anxiety. But that anticholinergic piece, it's kind of a double-edged sword. On one hand, it can actually help with sleep and take the edge off anxiety. On the other, it can cause annoying side effects like dry mouth. But this is exactly why you might choose it. You know that patient who felt totally wired or agitated on another SSRI? For them, paroxetine's less activating profile could be the perfect fit. Okay, so you've found your candidate. Excellent. Now for the game plan. Let's talk about how to actually dose and titrate this medication correctly. This is pretty much your standard playbook. You're going to start at 20 milligrams a day for the immediate release form and then bump it up weekly. But here's the really crucial part you can't forget, special populations. If your patient has renal impairment, you have to start lower, 10 milligrams, and keep that max dose lower too. Now you've got two versions to pick from, IR and CR, and the main thing to remember here is the big advantage of the controlled release form. If you have a patient who's really sensitive to side effects, especially nausea, choosing the CR formulation can be a total game changer for them. It could be the difference between them sticking with the medication or stopping it early. All right, every playbook needs a section on hazards, and it's our job to know them inside and out. Let's dive into the common side effects you'll be helping your patients navigate with paroxetine. This table breaks down the big four categories. For the central nervous system, sedation is a huge one. A lot of patients will feel pretty sleepy on this. In the GI department, nausea is probably the #1 complaint. But remember, the CR form is your best friend here. Weight gain can also be a really significant issue for a lot of people. And like pretty much all SSRIs, sexual dysfunction is common and usually gets worse as the dose goes up. Okay, we're shifting gears now from the common, manageable hazards to the serious red flags. These are the absolute must-know, deal breakers, and critical warnings. First and foremost, pregnancy. This is a big one. Paroxetine has been linked to an increased risk of cardiovascular issues in the baby, so it should be avoided. This is a massive clinical decision point. Next, always be on the lookout for activation. If you have a patient with an underlying bipolar disorder, any antidepressant, including this one, could flip them into mania. And of course, with all SSRIs, especially in younger folks, you have to watch for that rare but very real risk of suicidal thinking. And this one? This is completely non-negotiable. Paroxetine is a powerful inhibitor of an enzyme called CYP2D6. Thioridazine and pimozide need that enzyme to be metabolized. So if you combine them, you can get dangerously high levels of those other drugs, which can lead to fatal heart arrhythmias. So yeah, absolutely contraindicated, period. Okay, let's pull it in for a team huddle and talk about the patient conversation. When you're counseling someone about paroxetine, there is one topic that rises above all the rest: discontinuation. I really want you to let this quote sink in for a second. Paroxetine is infamous for causing a really, really tough discontinuation syndrome. We're talking dizziness, tingling, nausea, feeling restless. It can be incredibly miserable for patients. This is not a medication you can just abruptly stop. The taper has to be slow, and sometimes it has to be very slow. So what can you do for that patient who is just having a terrible time trying to get off of it? Well, here's a super practical step-by-step method you can teach them. It's often called the juice taper. They basically dissolve an immediate release tablet in a specific amount of liquid, which lets them make these tiny, precise dose reductions over a really long time. This gives their brain a chance to slowly adapt and helps minimize those awful withdrawal symptoms. And now, the final play in our book, presenting your plan to your attending. You've done your homework, you've made your choice, and now it's time to show them you know your stuff with these key talking points. You'll want to lead with the key pharmacokinetics. First, mention that it's a potent CYP2D6 inhibitor. That immediately signals that you're thinking about drug-drug interactions. Second, and this is a fantastic pearl to have in your back pocket, mention its non-linear metabolism. What this means is the drug actually slows down its own breakdown. So as you increase the dose, the blood levels can jump way more than you'd expect. It shows you thinking one step ahead. Next, you want to show that you thought through the major pros and cons. Acknowledge the big three trade-offs, that really tough discontinuation syndrome, the serious risks in pregnancy, and the potential for some patients to feel emotionally blunted or flat. This shows you have a nuanced, critical view of the medication and its impact on the patient. And finally, bring it all home with your why. Why this drug for this patient right now? You chose it because its less activating profile is perfect for your anxious patient. You chose it because those mild anticholinergic effects might just give them the extra help they need with their insomnia. This shows you didn't just pick an SSRI out of a hat. You selected a specific tool for a very specific job. So here's the bottom line. Paroxetine is not your everyday, first-line, one-size-fits-all SSRI. Think of it as a specialist's tool. It has some unique benefits, but it also comes with some really significant hazards. And the ultimate question, the one you have to ask yourself every single time, is right there on the screen. For my patient, right now, when do the benefits of this drug outweigh its considerable risks? Answering that question, well, that's the art of psychopharmacology.